Hello, everyone. I'm very pleased to be with you today, and I'd like to thank the organization committee for allowing me the chance to speak about the experience of heart-meat 3D activation in my center, Prince Sultan Cardiac Center in Hassa, Saudi Arabia. So this is my center, and I have no disclosures regarding this talk. So we are speaking about advanced heart failure cases, and as we all know, heart failure affects more than 1 to 3% of the population worldwide. There are 6 million patients in the United States alone, and here in Saudi Arabia, we have more than 500,000 cases, with the 1-year mortality of the advanced heart failure patients is about 60%. And more than 5% of the patients may require multiple hospital admissions. And as you may know, this impair the quality of life of the patients, and it also causes debilitation of the healthcare system resources. So the treatment options, we have the medical treatment, and we have the cardiac transplantation, which is the standard or the gold standard for the management of advanced heart failure patients. And we have also the mechanical circulatory support with the LVAD implantation. We're not going to speak about the medical treatment because we are speaking about the category of patients who are very advanced and they reach to a state which is beyond the medical treatment. So we are speaking about transplantation, which is the best option. But we have donor unavailability, and only 5,000 transplantation occur each year worldwide. And we have at least 10 times this figure needing this surgery worldwide. That's why the development of the VAD devices was very good for those patients, as the LVAD is readily available on shelf, and it gives better results compared to medical treatment, and it can be used as a bridge for transplantation or recovery, and it is also FDA approved even for destination therapy. So our VAD program in Prince Sultan Cardiac Center started in 2017. We have implanted 36 patients up until now. Our program is a part of the Euromax registry, and all of our patients have been on the transplantation waiting list. We have implanted LVADs for 34 males and 2 females. 2 patients have received heart transplantation after LVAD implantation, and 6 patients have recovered, and their LVADs have been percutaneously deactivated successfully. This is a part of the social events that we do to the LVAD patients, and because, as we know, those patients require very good rehabilitation after implanting the LVAD. This is an interesting photo sent to me from one of the LVAD patients, and it shows how he's enjoying his life after LVAD implantation. So now I'm going to speak about the recovery program. So as we now know, most VADs are used as a bridge to transplantation. However, in certain cases, myocardial function recovers and VADs can be explanted after the patient is weaned. And we know that surgical explantation is the gold standard. However, minimally invasive percutaneous deactivation has been described as a successful alternative. And within our study, I'm going to present the experience in our Center for LVAD implant deactivation. This is our recovery protocol. So all our LVAD patients are reviewed by echocardiography every 1 to 3 months. Reduction of the left ventricular dimension is used as a key feature to detect potential candidates for LVAD deactivation. Potential candidates were further evaluated with a recovery test. In this recovery test, the patient received 5,000 international unit heparin, and then his LVAD speed was ramped down gradually till 3,000 RPM. Echocardiography is used to determine the LV ejection fraction and also the LV dimension. If we reach an ejection fraction of more than 40%, we can consider this as a recovery sign. After that, we use the dobutamine, low-dose dobutamine, to detect further improvement of the LV function. Thereafter, we discuss all the data, of course, with the VAD multidisciplinary team in our center and with the patient family. And all the patients that reach this criteria accept to go for LVAD deactivation. This is an echo representing the LV function and also the dimensions before the LVAD implantation. It's just with eye pooling, we can notice that the function is very low and also the dimension is very large. I don't know what's going on. Go to the next slide. This is the post implantation, and we can notice how the LVD loading lead to a little bit reduction in the LV size. I don't know why it's and this is during the recovery test, and we have ramped down the LVAD speed to check the actual dimension and ejection fraction of the patient while the LVAD speed is 3,000 RPM. And this is after administering dobutamine. And this photo is after deactivation, and we can notice that the function is pretty much better than the pre-implantation echo, and this is the long axis parasternal also. As we notice, the bump itself is still present, as we do only percutaneous deactivation. We don't explant the bump from the patient surgically. So why do we need to deactivate the LVADs? As we all know, there are a lot of complications that happen while LVAD therapy, and the GIT bleeding is one of the most important complications that happen to patients on LVAD therapy. Also stroke, also drive line infection, which is one of the most common complications, and hemolysis, progressive RV failure. All these complications, for all these complications, we need to deactivate the LVAD if we reach to the criteria of deactivation. How to deactivate? In our center, we deactivate the LVADs in cath lab under fluoroscopy, and TEE is used to guide the process. We use two Amplatzer devices to plug or occlude the LVAD outflow graft, and I'm gonna show you the images from the cath lab, how we are doing this. And finally, the position of the device and its occlusion rate is confirmed by aortography. And after the deactivation, just we cut the drive line via a small incision in the subxiphoid area, and then remove the drive line from its orifice. So this is from inside the cath lab, and this is the first aortography to check the autoflow graft. Here we can notice the first implanter device. This is the one, first implanter device. And here we can appreciate how the first implanter device is pushed towards the beginning of the pump itself to occlude the autoflow graft. And this is the second implanter device. This is the end results, both implanter devices occluding the autoflow graft. And after that, we do small subxiphoid incision and we cut the drive line. And after that, we remove the drive line via its orifice. So till now, we have done six patients. The mean deactivation length of stay post-operative, I mean in the hospital, was 7 ± 4 days. The follow-up duration is more than 1.5 years. The ejection fraction post-deactivation was more than 40, and the left ventricular end diastolic diameter was less than 6, and mean pulmonary artery pressure less than 20, and our survival rate was 100%. So the use of LVAD therapy for advanced heart failure patient has surged during the last decade, and with some patients manifesting left ventricular recovery, and others also may have complications, and this is necessitating the LVAD explantation. And because of the hazards of the surgery, the development of minimally invasive approach is a necessary requirement. That's why a program for LVAD deactivation was developed in our center to complete all the aspects of a successful heart failure service. There are some concerns that need to be addressed during the future and needs further research. This is the presence of the device itself attached to the LV apex. We know that this may predispose to infective endocarditis, but we need more research and more follow-up to know the percentage of people that may reach this complication, to check whether this necessitates surgical explantation of the device itself or not. Also, the anticoagulation management, till now, there are no consensus regarding the anticoagulation management. If we need to continue with warfarin, or we can go for the NOACs. In our center, we keep warfarin for at least 3 months after deactivation, and if there is no other indication for anticoagulation, we shift the patient to aspirin after that. And so we need further follow-up to address the answers to all these questions. In conclusion, percutaneous heart mid-3 deactivation appears to be a safe alternative to surgical explantation, and the survival after the procedure was 100% and no events till now, especially thromboembolic events. Thank you.